So again, our lab today starts on page 27, looking at the objectives, knowing the different parts of the neurological exam. So these are the 6 parts of the neurological exam, and we're going to go through each of those in a real general way, just so you have an understanding of what each of those pieces looks like. And a lot of the information you can see in the video that I put on Blackboard. It's the complete neurological exam. So if I tap on that, we see Dr. Blumenberg here and his patient he's demonstrating the different components. So if we look along the left side here, these are the 6 components of the neurological exam, and he goes through each one of these explaining how we would assess mental status. Now, you don't need to go and watch every one of these. Like I said, this is more information that we need to know than we need to know for this lab. But one thing that I can tell you that I use when I'm working with my patients when we're looking at mental status, we ask them this pretty basic question of orientation, and we look at the level of alertness. So when you come to the bedside, you say, "Hi, my name's Jill. I'm going to be your nurse tonight. How are you doing?" And if they can respond to you and they look at you and they open your eyes, then you know that they're alert. Looking at orientation, just conversation with them. "Oh, so what brought you here with us, today?" And if they appear confused, then you do an official orientation where you ask them, "Tell me your name, tell me what the date is today. Do you know where you're at? Do you know why you're here?" Those are all things that we use to assess their orientation and if they're aware of their circumstances. So mental status is an important part of the neurological exam, and a lot of that is a conversation with the patient. But then you can also have them perform certain functions, have them writing, reading, calculating, testing their memory, things like that. But that's not something a nurse would typically do unless you work on a neuro unit and you're working with a neurologist who's working with maybe stroke patients or people that are being diagnosed with Alzheimer's and things like that. But that's quite an extensive test, not something we do typically unless there's, like I said, something significant happening. So then the second part is cranial nerve function. So there are 12 cranial nerves, and you have to know, not for the lab exam, you have to not only know just the name of the cranial nerve, but also what type of nerve it is in terms of, does it carry sensory information, motor information, or both? If it carries both sensory and motor, we say that it's a mixed nerve. And I'll show you in our PowerPoint here what that looks like. So there's 12 pairs of cranial nerves. You can see the red lines indicate sensory information, so that means it's bringing information from the external sensory receptors into the central nervous system. So it's incoming information. And then the blue lines represent outgoing information, so it's a response. It's some movement that you're going to see in the patient as a result of the central nervous system stimulating that organ to move, or to contract, or dilate, constrict. So if we look at some of the nerves, you can see they're only sensory, and other ones are only motor, and again, some are mixed. So if we go to your lab objective page here, in the actual reading part, part B, you'll see that the 12 cranial nerves are listed here, and then it tells you the fiber types. So the olfactory nerve, cranial nerve number 1, is only for smell. So it only brings sensory information from the nasal cavity into the brain, telling you what that smell is. And the optic nerve is also only sensory. It's only bringing light information and converting it to an image, so that light information stimulates sensory receptors in the retina, which is where the sensory receptors are for light in the eye, brings in through the retina. The oculomotor, trochlear, those are for movement, because if you look at their function, it's constriction of the pupils or eye movement, up, down, side to side. So the motor is some response coming from the central nervous system, and in this case, it's eye movement. So the trigeminal and the facial nerve, those are 2 mixed nerves, which means they have some sensation component. So there's a sensory component, and yet there's a motor component as well. And again, if you look at your pages in the back of our lab packet today here, or in the back of this particular lab, it tells you the nerve, what kind it is, sensory, what it controls, and how you would assess it. So if you can come up with, a basic assessment for each one of these cranial nerves, using this table, that'll set you up for, knowing how to do that neurological exam, looking for that cranial nerve function. Okay, so going back here then. So there's a mnemonic that you can use to memorize all of these cranial nerves starting from top to bottom, 1 through 12. And there's a number of them out there that medical students have come up with, and some of them are a little off color, so I had to do some searching to find some that are appropriate for presentation in class. And let's see, I can find it here. It's in one of my Blackboard sites. Here it is. So old Opie occasionally tries trigonometry and feels very gloomy, vague, and hypoactive. If you could remember that, that's the olfactory, optic, oculomotor, and so on. So that's one way to remember the order. And then maybe you can take a highlighter and highlight which ones are mixed nerves, or use a color code or something to determine which is sensory, which is motor, which is mixed, and then how you would assess each one. Okay, so going back to our objectives here then. So cranial nerve function is something that is part of the neurological exam. Again, there's 12 cranial nerves. And then motor function. So motor function is looking at functions of the spinal nerves. So if we go to our PowerPoint here, we have 31 pairs of spinal nerves coming off of the spinal cord. Seven in the cervical region, 12 in the thoracic, 5 in the lumbar, and 5 in the sacral. So every nerve has a sensory and a motor component. So we can say that all spinal nerves are mixed nerves. So they carry both types of information. So out here is a spinal nerve, and then as it gets near the spinal cord, so here's the spinal cord, as that nerve comes closer, it divides. So we have like a 2-lane highway here, and then it becomes a 1-way. So we have sensory information coming in this way, and then motor information is coming out this portion, the ventral portion, out to some effector cell. So there's 2 types of motor neurons, or I shouldn't say 2 types, but there's 2 types of neurons bringing information away from the spinal cord. One is an autonomic neuron. So autonomic neurons that's the involuntary part of our nervous system, that would synapse on like a smooth muscle, cardiac muscle, a gland, those things that are not under voluntary control. Or it could synapse on a skeletal muscle, which is under voluntary control. So that would make it a somatic motor neuron. So this output portion of our spinal nerve could either be autonomic or somatic. And we're going to look at reflexes. There's 2 different types of reflexes that we see. Some are autonomic, and some are somatic. And we'll talk about the differences between those. So when we're looking at motor function then, we're just looking at those spinal nerves and determining if the motor pathway is functioning properly. So we'll ask the patient to do certain things that involve movement. For example, putting their arms out in front of them and asking them to just hold them out front and see if they have enough strength in those muscles, or do the arms drift downward. Then we know they have impaired motor function. Or we might ask for resistance against our pressure or our touch. So if we go back to the objectives here, looking at motor response. So I'm talking about looking at strength. So when we hold them out, when they ask them to just hold their arms out, we're looking for strength against gravity. Can they just hold them out? And then if I push on them and I say, can you resist my pushing of your hands downward? Then you test for strength against resistance. So there's gravity and resistance. Then we can also look at the size of the muscle. Does it look smaller than normal because of disuse or disease? We call that atrophy. Does it look larger than normal because of exercise and weightlifting? Then we call that hypertrophy, which is bigger than average. We can look at the tone of their muscle. So when they're lying there and moving, do they have good tone in terms of there's a little bit of contraction of the muscle? You can see there's a shape of a muscle. If the muscle is flaccid, you don't see the outline of the muscle through the skin. and it's, doesn't have a response. It's just very floppy. Stiff or rigid, those that have like cerebral palsy or sometimes recovering from a stroke have kind of spastic movements. They don't have that control. So that's another test of motor function. And then coordination, touching finger to nose and finger to nose, or dragging the heel from the ankle to the knee, the opposite heel from the ankle to the knee and back down again. That's a coordination thing. And then asking them to just simply walk on their heels, walk on their toes back and forth, looking at that coordination. Can they do it without stumbling? And is there, does it look symmetrical on both sides? And then you're just looking for abnormal movements. For example, a person with Parkinson's, for example, would have tremoring, or fasciculations, we call that, when they are moving their, there's extra motions outside of the normal movement that you're asking them to do. So that's a motor function test, and there are some examples there in that neurological exam that test motor functions. You can look at those. And then the somatic reflexes. There's a number of somatic reflexes you need to know. All of the ones that we're talking about are deep tendon reflexes, and we'll talk about that in just a minute. But you need to know the stimulus and the effector and the response. So if we go to the PowerPoint here, we look at the reflex. So here's a deep tendon reflex. So when we tap on a tendon, for example, the patellar tendon with a reflex hammer, that stretches that tendon, which is relayed into the muscle, and there's this tiny little organ deep in the muscle, which is called the muscle spindle. And when that is stretched, it fires off a sensory neuron that detects that stretch, which then will activate motor neurons that go to the muscle of the quadriceps and cause it to contract, and the knee kicks out. So this is a reflex in the sense that there is not any requirement for the brain to be involved. So whenever we have a reflex, we have some sensory receptor that is stimulated, carrying that information along a sensory neuron into the spinal cord, but rather than going up the spinal cord to the brain to cause a voluntary response, that impulse, that action potential, jumps right across via an interneuron to the motor neuron, which will stimulate that muscle to contract. So make sure you know the parts of a typical reflex arc. There's a sensory receptor, sensory neuron, interneuron, motor neuron, and effector organ. That's the part of a reflex arc. Now this is a somatic reflex because the effector organ is voluntary skeletal muscle. An autonomic reflex would be the same, have the same pathway, except for the effector organ would not be skeletal muscle. It would be what? Smooth muscle, cardiac muscle, or gland. That's the autonomic organs. So if we go down here and look at the pupillary light reflex, this is an example of an autonomic reflex, and I just added this before class, so this is updated now, so you'll have this. So if I shine a light in the eye, it is going to cause that pupil, the dark spot in the center, the hole in the eye essentially, to get smaller. It constricts or contracts. And the iris is the muscle, the smooth muscle that responds to that. So that's the effector organ, is the iris contracting and causing that pupil to be smaller. So if I shine that light into the right eye, I'm going to see both eyes, the pupils constrict. So it's called consensus. So you only have to shine it in one for both of them to constrict. So that's a sign of an intact pathway of that reflex arc. And again, whenever we look at reflex arc, we're testing the function of the sensory neuron and the motor neuron. And in the case of the pupillary reflex, what are the neurons? Well, light shining in the back of the retina is going to stimulate cranial nerve number 1, which is the optic nerve. And if you look at your list, the optic nerve is only a sensory nerve, right? It only carries sensory information, so it carries light information into the brain, and it actually crosses over to the other side of the brain. So you don't need to know the parts of the brain here. But it goes to the brain, and then it causes a response, because this is a reflex, so it's going to jump over via an interneuron back to the motor. And what is the motor neuron serving the eye? If you look at your list of cranial nerves, you'll see the oculomotor nerve is the motor neuron that serves the eye. So that impulse then jumps to that neuron, that nerve, the neurons in that nerve, and that goes out and causes the iris to constrict and make that pupil smaller. So that's an example of an autonomic reflex. You've got the sensory receptor, which is in the retina. What's the stimulus for that? What stimulates the retina? Light. Yep. So we shine a light on the retina, and that's where the sensory receptors are. Fires off an action potential down the sensory neuron, which in this case is the optic nerve, to the brain. There's an interneuron here in the brain, which connects that action potential then to the motor neuron, which is found in the oculomotor nerve coming out again. And the effector organ is the iris, the smooth muscle of the eye. So we're not going to ask you to know the specifics of the pupillary reflex in great detail. What we are going to ask you to know, and this is in objective, let's see where that one is. I thought I saw it in here, a specific one that you had to know.
Under number 6.
Yes, thank you. Yeah, right, yep. On page 27, it's objective number 6, number 2, letter B, number 2. It says describe in detail the stimulus is light, the sensory receptor is the retina, the cranial nerves involved, so optic and ocular motor. The effector is the iris, the smooth muscle of the iris. The response is pupillary constriction, and it is consensual, which means both eyes will constrict. So this is all described for you. You don't have to write this down as I talk, obviously, because it's all listed for you in your reading on, let's see, page 29 at the bottom. There's a paragraph there. It says one example of an autonomic reflex is the pupillary reflex. So look at that, read through there, tells you everything you need to know for that. So there's not a lot you have to write down for today's lab. It's more just knowing where to look, and it's all there in the reading. All right, so then looking at sensory function, there's a special map that we have of the surface of the skin, which are called dermatomes. And dermatomes are a region of sensory innervation at the skin. So, for example, we have lumbar nerves 2 and 3. If I scratch the surface of the skin, lightly touch it, say with a Q-tip, and they feel numbness there, we know that there's damage to the sensory neuron of spinal nerve L2 and L3, okay? So that's what the dermatomes measure, is that sensory information of that spinal nerve, because we said spinal nerves are mixed, right? So there's a sensory pathway and a motor pathway. So the motor pathway, again, would be some movement, right? Some activity that those nerves are, the motor neurons are stimulating, but the sensory portion is just at the surface of the skin. And this is really informational, because I had a patient that had a dependence on narcotic pain relievers, and she was in a car accident, and what she was telling us is that she injured her L4 and L5, and that's why she has such pain in her quadriceps when she walks, and therefore she needed more pain medicine. We went for a walk because she had this numbness and tingling in her quadricep because of having a damaged L4 and L5. So the doctor came in, and I said, you know, her story isn't measuring up. And the doctor came in and he said, okay, where did you injure your back? And it was an old injury that she had. Yep, L4, L5, and that's why I had this pain in my quadricep, this numbness and tingling. Yep, right there. He said, anywhere else in your leg that you have pain or numbness that you notice? Nope, right in my quads, because she's thinking, you know, that's close to where the lower back is. That would make sense, right, that you would have numbness and tingling there. Well, the doctor went out in the nurse's station and pulled up this exact picture. And he said, interesting, because she should have pain where? Or not pain, but numbness or tingling where? in her calf or even near the ankle. But that's not where she was describing the issue was. So not knowing her anatomy and physiology, we were able to find out that she was not necessarily accurate in how she was describing her condition. But now, on a side note, if a person is addicted to narcotic pain medicines and has surgery that is very painful, do they have a right to pain relief? Yes, every patient, regardless of their history, if they've had a surgery or an injury that causes pain, we don't deny them pain meds and say, oh, you're an addict, you don't get to have this, right? That's not fair. Every patient deserves pain relief when they're in the hospital. So we deal with the narcotic addiction by offering alternatives, you know, but we don't deny them the pain relief that they deserve. So anyway, so that's what dermatomes are. So we're checking sensory function. And then there's a lot of other tests that we can use to detect sensory function, and that is in this video. Coming down here, the sensory exam, a lot of different things that she does here to determine sensation. And in your lab packet, at the end, it talks about the different types of sensory function that we can assess. So we can look at temperature, hot and cold, that's one type of sensation that's different than dull versus sharp, and vibration. So when you tap a tuning fork, it vibrates, and we can put that on the surface of the skin and ask them if they can detect vibration or no vibration. So that's one thing that we can check. For example, I had carpal tunnel in one of my pregnancies because of water gain and pressure on the nerve and the nerves that run through the wrist. And as a result of that, I feel like I still have good sensation on my fingertips, but I didn't know that I was missing sensation because they did a special test. He said, just look the other way, and he took my hand, and he had different brushes with different fineness or stiffness, and he tested my fingertips, and when he was done, he said, okay, I'm done. And I said, well, you're going to start? And he said, well, I'm done. You didn't feel any of the tests on your fingertips. And I was like, oh my gosh, I did not know that I lost my fine touch perception, and I did. And I didn't get tested again, so maybe I still have some fine touch. But I do notice that when it gets cold and I reach into the shower to test the water, when it's very hot, my fingers perceive it as ice cold. So it's strange, and my left hand is worse than my right, so it's something. But if I use my hand, I don't have that. So it's not like I can't tell hot from cold when I get in the shower. I just have to use the top of my hand rather than my fingertips. So there's those little changes that can happen with nerve damage that are subtle, and you just don't know unless you have a test for it. So we have these bags over here on the side of the lab. They're called stereognosis bags, and what they are is just, I think, are they in? It's in your lab packet here. It's a bold term here. Stereognosis right here. So you'll reach into the bag, for example, and there'll be some items in there. There might be a thimble in there, or a spool of thread, a penny, a quarter, paper clips, and you just have to feel it and say, okay, I can tell that it is this. And that just is a way of checking sensory function in the fingertips, that they can distinguish among different shapes and things. Like if they're, like you can test warm versus cold, have them dip their hand in cold water versus warm water. 2-point discrimination would be where you would take a paper clip and bend it into a U shape and then touch their skin and ask them, am I touching you with 2 points or 1 point? And then they can tell you 2-point discrimination if they can feel both of those points on the surface of the skin versus one. So those are other more specific ways that we detect or assess sensory function. And again, when we're talking about sensory, we're looking at the spinal nerves, when we're looking at the stereognosis bags, or looking at anything over the surface of the skin. But when you get up to near the face, when we're touching the face, that would be cranial nerve number 5. So if you're brushing something on the cheek or the chin or the forehead, if you look at your list of cranial nerves, you can see that has sensation on the face. So just be aware of that. So let's look at the Romberg test. I want to just draw your attention to that particular test, because he demonstrates it here.
In the Romberg
So
test, we remove visual
close her
input
eyes,
so that postural balance must be
and he's going
maintained
to
entirely
test
based
if
on
she has good
vestibular sense
equilibrium
and position sense.
by
Can you
tapping
please
her,
stand
pushing
with
her
your
in
feet
one
close
direction to
together,
see if she
touching
can
each other?
correct without opening
now
her
close your
eyes or
eyes,
taking a
please.
step to the outside. So she's closing her eyes, and now he's gonna push her.
Very good. Keep
Usually
your
it's
eyes
a little more
closed.
gentle. He's actually kind of rough in the way he does it. Must be his wife or something. 'Cause but she corrects, and no issues there. So that's a negative sign. That's a negative Romberg if it's normal. If she fell, then we call that a positive Romberg, and that's a sign that there's an equilibrium problem. And what cranial nerve is in charge of equilibrium? Take a look on page 29. So there might be damage to the sensory pathway of, yes, cranial nerve number 8, vestibulocochlear. So that detects hearing, that's sensory, and equilibrium. So there would be damage to that nerve. So that's the Romberg test. Another special response that I want to draw your attention to is in the PowerPoint, looking at the different deep tendon reflexes, the Babinski's reflex. Normally when we take an object, like the back side of a reflex hammer has a blade end that's dull, but you scrape it up the side of the foot and inward, it causes the toes to curl inward. So that's a negative sign, which is a good thing. That's what we want, is the toes to curl inward. But if they splay outward, or what we call dorsiflex, that's a positive sign, and that's a sign, an abnormal response. And that is normal in babies 2 and under. So a positive Babinski is normal in kids 2 and under, but it's a bad sign, abnormal, in anybody over the age of 2. So we don't want to see a splaying out of the toes. And that's the plantar reflex that we're looking for. The Babinski sign, again, is a splaying out, which is not normal. And again, if you look at the different reflexes, I do recommend that you look at those to see what the normal responses are. I'll show you hers.
Test the plantar response using a sharp object such as the back of a reflex hammer and drawing
So he
it
just takes
straight
the back
from
side
the
of the reflex
heel
hammer,
along the sole of the
runs
foot
it
in
up
an
the
arcing
side.
motion towards the toes, and observe the first movement
You can see how her toes
at the
curl
proximal
inward.
joint of the great toe. The normal response is flexion. Extension is the abnormal response, also called the Babinski sign.
Okay. So, are there any questions about today's objectives? If we go back up here to the first page, we talked about there's 31 pairs of spinal nerves. They're all mixed nerves. There's 12 cranial nerves. Some are purely sensory, some are purely motor, some are mixed. You have to know what they serve and how to test for them. The different tests, you can watch the video. We talked about the different reflexes. We talked about the arc, the reflex arc, the components of it. Talked about the response of the plantar reflex in an infant versus an adult. We looked at what the Romberg test is. And then we talked about sensory function and the stereognosis bags, where you're just feeling for different objects. So we're looking at the sensory pathway of the spinal nerves with the stereognosis bags. And I remember a lab exam question regarding that. What are we assessing with the stereognosis bags? And we're assessing sensory function of the spinal nerves. And the motor function would be, the coordination and the muscle strength and things like that, and asking them to perform certain movements. And again, you can watch the video if you want to look at specific assessments for the motor function. So then let's look at the worksheet. 6 components of the neurological exam. Those are listed on page 27, objective number 1. So we're not going to go, I'm not going to rattle those all off. You can read those on your own. And the tests are described either in the video or in your reading. Number 2 is name an appropriate test for the different cranial nerves. And if it's a mixed nerve, they want to know what is the sensory portion, how would you test for the sensory portion, and then how would you test for the motor portion. So again, those are all listed in that chart in the back of your lab packet. And then the stimulus for each of these, we can talk about this. What is the stimulus for the patellar reflex? It's the knee-jerk response. I saw the motion. Tapping the tendon? Yeah, tapping the tendon with the reflex hammer. That's the stimulus. And what is the response? Yeah, kicking the lower leg out. Yep. Or contraction of the quadriceps. And then is that a somatic or autonomic reflex? Somatic, because it's skeletal muscle that's responding, right? It's a voluntary muscle that is that's the effector organ. It's what's responding is the kicking out of that skeletal muscle. The pupillary reflex, what's the stimulus? Shining a light, yep. And then what's the response? Constriction of the pupil, yep. Contraction of the iris, causing constriction of the pupil. And then what type of reflex is that? Autonomic, because remember, autonomic is any organ that is cardiac muscle, smooth muscle, or a gland, the involuntary part of our body. So the iris is smooth muscle. So that's an autonomic reflex. Define a dermatome. You can just copy that right out of your reading in your packet. That's pretty straightforward. What is the maximum number of dermatomes that can be assessed? All right, so 31 pairs of spinal nerves, so 31 dermatomes. And the rest of the worksheet is just matching up the different cranial nerves with their function or their type. You know, the type of fiber, motor. Again, you can just look in the chart. We're not going to go through that. I think that'd be a good review for you to really get up close and personal with those cranial nerves. But I do want to draw your attention again to what I put on Blackboard here for you. And that's the online flashcards and games for the cranial nerves. And then I put that mnemonic there too. So make sure you take a look at that and use that to learn those cranial nerves. Because you'll need to know them again when you get into your programs, depending what program you're going into. But for nursing, I know we look at the cranial nerves and it'll help you get over the hurdle of learning all those. So if you don't have any questions, then that concludes the content.